Welcome everybody who's tuning in. If it's evening where you are, good evening. If it's morning, good morning. Wherever you are, welcome to Fair in Medicine's webinar. We are continuing our series on informed consent. And we tonight, I am happy to have a guest who has been a part of the process of helping to patients understand the information that's provided to them by their doctors about medications, and who has just really been honing in on the safety of medications that come to market. But before I begin, just a reminder, Fair in Medicine is the medical arm of Fair for All. You can find out about us at fairforall.org. We are a nonpartisan organization, nonprofit organization that is actively trying to change the conversation and the landscape, and trying to get away from just all of the partisan noise and really get back to honing in on what matters to people, and just treating each other like human beings. So we are run by donations and volunteers. And so we'd love to have you sign up and join us, and take part of what we're doing. And you can join subscribe to our newsletter to hear about all the upcoming events that we're having, and find out how you can be a part of a part of Fair for All. Informed consent is a central component of developing trust in the doctor-patient relationship. Informed consent, if you don't know, is the process by which patients are given information about the way medications, treatments, or research is going to work, what the possible benefits of those treatments and medications or research process will be, and it will and the possible risks, and then alternatives to those treatments or research or medications. The purpose basically is to have the person prescribing or recommending the treatment, or enrolling the person in a clinical trial or research trial provide all of this information, so that the patients who are receiving or helping to make a decision about their care or their participation in the research can actually make that decision with all of the information that about how it's going to affect them. And what is concerning, though, is that roughly 29% of Americans are concerned that they actually don't know the risks of medications that are prescribed to them. That's only one of the data pieces we have. There's also been, most recently, the lack of transparency about true effects of things like the COVID-19 mRNA vaccinations, puberty blockers for children with gender dysphoria, sex hormones, same thing, prescription opioids, benzodiazepines. All of these concerns and this lack of transparency has a lot of people, including myself, distrusting the medical system. So Fair in Medicine began exploring this topic a few weeks ago, and tonight we have Dr. Adam Urato. He will be here to discuss informed consent and pregnancy. Dr. Urato is, welcome, sir.
It's a pleasure to be here, Nikki. Thanks for having me.
Awesome. Let me give you a little bit of background on Dr. Urato. My computer is actually taking a little bit of time. He's located in Framingham, Massachusetts. He is a maternal-fetal medicine OBGYN. And here we go. My computer was acting like really long, really slow. He attended Harvard College and Harvard Medical School, and completed his residency at Mass General Hospital and the Brigham and Women's Hospital. His Maternal-Fetal Medicine Fellowship was at Tufts Medical Center. He has an active clinical practice right now. He's taking care of high-risk patients in high-risk pregnancies and delivering babies. He writes and lectures on medication exposure and pregnancy. So I'm floored and just really excited to have him and his expertise talking to us this evening. So thank you so much for joining us, Adam.
Thank you for that nice introduction. I think you touched on some very important things there, in particular, the informed consent piece of it. I think that that's very, very important. I'm like a local community physician, so I'm taking care of people in my hometown, and I think it really helps to hit home this fact that this importance of informing people and allowing them to make the best choices for themselves, and then supporting them in their choices. It's a physician-patient thing, but it's also personal because of the sort of physician that I am in the community, so that I think that it even brings these issues about informed consent and information for patients more to the even more to the forefront, and particularly in pregnancy.
Yeah. I, this is, gosh, this just, are you finding that physicians are trained the same way or very differently in terms of how they approach informed consent? And maybe if you are involved in teaching the next generation of doctors or residents, do you personally take the time to teach those trainees and those medical students how to provide informed consent? Is that something that's important to you?
Yeah, I think it's a good question. I think physicians want to, I mean, I know my friends, my colleagues, people who work in the field with me want to do, for the most part, the best they can for the patient. But there's often limitations and there's often restrictions on that ability to actually provide informed consent to patients. One is just the time element, where physicians are often pressed for time in a busy clinic or in a busy hospital setting. You're often just pressed for time. And the second limitation, I think, to really getting informed consent out there for patients is that oftentimes the doctors aren't necessarily informed, or none of us are, about the issues and the risks of some of the medications and the procedures. And I think part of that is that to some extent, we've got I'd say a broken regulatory system or a broken information system when it comes to medications and also with procedures, but medications in particular, which I'll focus on. We really rely on these drug company funded studies and the drug trials, and a lot of our information that comes out is information that's coming out from the pharmaceutical industry. And that information has more of a monetary goal, more of a financial goal, which is to sell the product, than it does have an informational goal. So patients and physicians that are relying on information that's coming from pharma are going to end up with this sense of medications that they tend to be safer or promoted as being safer than they actually are. They tend to be promoted as being more effective than they actually are. And then the alternatives often aren't emphasized at all. And that information comes out to physicians in various ways, and also to patients, and makes it hard to actually provide that information to patients that they should have.
Yeah. What's very interesting is as you were talking about that, I'm reminded about my training in residency. It's over 20 years ago, but I remember at that time we were allowed to have pharmaceutical reps come and provide lunch for us during like an afternoon conference. And as we went through the line, those pharmaceutical representatives would be there trying to talk to us about the medication that they were selling, right? But we had time gathering up our lunch to ask them particular questions about the research and the data. And I remember that being a big part of my training program and how we learned about medications. We didn't just rely on the information that they gave us. They would print out their little handouts and tell us about their trials. But if there were questions that we had, we asked them directly. And if they couldn't provide us that information, then clearly there was a component that was missing. And for us, we weren't just going to go and just prescribe something because the pharmaceutical rep was there, handing us a pen and, that was reminding us that that medication existed. We were actually thinking about it and thinking it through and having open discussions about these new medications that were coming to market. And I just don't, I think, there were, when Stark laws came about and really forced physicians, particularly, specifically physicians, to kind of report and disclose all of their, the contributions from pharmaceutical companies, a lot of this disappeared in our training programs. And so some people were happy. Some of the older physicians that did not grow up around that type of environment where there were pharmaceutical reps everywhere marketing their drugs to them in that manner, they were fine with it because they knew that they could actually go to different sources and find that information. But my generation, what we had really was the marketing from the pharmaceutical reps. We didn't really have like these major texts that we could go to that because the drugs were like being manufactured so rapidly, there was no way you could keep track of all the new drugs that were coming aboard and then or have a single source where you could go to and kind of look up the details of all of these drugs and be confident that you understood the risk and side effects. We have a different, it's just the context of things right now is completely different. We have what, like you said, what the pharmaceutical companies are telling us about. And if they're going to tell us the positives of their research studies and not tell us the negatives, then that's all we are beholden to. And if we don't have the opportunity to interact with them, to ask them these questions and to press them for this information, I think honestly that is contributing to some of this just kind of hurry and fix it, nature where physicians have a limited amount of time in the exam room with their patients to kind of go through the details and also just learn about the products themselves. And so I think that's a big part of this. And I'm not making excuses for doctors who are not providing informed consent, because that is unethical completely. If you don't know everything about a drug, you should not be prescribing it, period. But I just think the environment that we're in right now makes it a lot easier for that. And it actually almost it caters to that type of learning about drugs. I don't, you and I probably are about the same age, so I don't know if that, if you see a difference, in time, compared to your, training and now what we have.
Yeah, I think you were describing a discussion, which is an important aspect of this, which is that you would be able to talk or discuss things through, whether it was with the drug reps or with colleagues, about trying to sort of drill down into the issues related to a drug. What are the risks? What are the benefits? What do the studies show? But that requires a fair bit of time to be able to have that time and be able to do that. Nowadays, a lot of the information that people are getting is just kind of coming out in sound bites or commercials from the pharmaceutical industry, which is really limited. The other point I think you raised, which is a really good one, is that and John Abramson has a relatively new book. It's a couple of years old about this, but about how the pharmaceutical industry in a lot of ways is basically controlling the flow of information with their studies. So even if you're a diligent physician, you're a conscientious physician, and you want to find out all of the information you can by looking into the studies, in some of these studies, the information has been withheld. It's been basically they've lied about the data is what it comes down to.
Yep.
Vioxx is probably the one people know about most, where the heart attacks were basically just sort of hidden. And so it showed the drug to be safer than it was. It didn't show the heart attack effect. And then it got FDA approval, it got rolled out, and sure enough, we started seeing heart attacks. Tens of thousands of people died from Vioxx, and that was known from the data, which was essentially, it appears to have been hidden by the drug company. So even for a doctor or patient trying to drill down to get the information, it can be challenging. It can be challenging when that sort of thing's going on.
Absolutely. So so let's hone in a little bit on that. So let's talk, briefly about the process by which drugs get approved by the FDA. And maybe we can go through the specific example from the drug Makena and how that went down. And then we can talk a little further. So
yeah, Makena is like a great case study to understand. I try to tell people, obviously I care a lot about it because I was involved in it, but I think just as a case study, it sort of points out a lot of the flaws in our drug regulatory system and the way we use medications. So Makena is a synthetic hormone. It's related to progesterone. It's a progestin, but it's a synthetic hormone, meaning it's not naturally occurring. It's made in a chemical manufacturing facility, and it's synthesized. It's a synthesized progestin. It was used back in the 50s and 60s to try to prevent complications of pregnancy. It was called Delalutin, and had some other names at that time. And then that was during the heyday of using hormones in pregnancy. DES and other ones were being used in the 50s and 60s. And then it sort of fell off the board for a while until it was decided to try to restudy it as a way to prevent preterm birth. And so the FDA relies on randomized controlled studies in order to be able to give approval. Typically, you need two. You only need one for accelerated approval, and that's what this drug got. This drug in 2003, there was a study called the MEIS trial, MEIS. Paul Meis is just the first author, but people refer to this trial as the MEIS trial. And it was a randomized controlled trial, and it did show a statistically significant decrease in preterm birth in the women that got the drug Makena. Back then it wasn't called Makena, but it was 17P. The problem is that the trial was really flawed from the get-go. The initial randomization that they did, when you do a randomized controlled trial, I don't want to give a big lecture on this, but when you do a randomized controlled trial, the purpose of randomization is to have basically equal groups. But they didn't end up with that. When they did their randomization, the group that was going to get the placebo was a much higher risk group. That group had a lot more prior preterm births. The group that got the drug Makena was a lower risk group. The randomization essentially failed. And then there were problems with this.
So was there a question about how the randomization process was conducted there?
Yeah, I've never seen that looked into. It's a good question, Nikki.
Yeah.
I mean, it could be that there was something that got tinkered with the randomization process, but it could also be that even with the randomization, certain characteristics just by chance could sort out not equally. And so I think that's what people thought had happened here. They just did it in a randomized fashion, but it just happened that the group getting Makena ended up being a lower risk group. Now, could there have been something else going on, something more nefarious? I guess there could have been, but it also could have happened.
I got alarm bells in my head. That just sounds shady to me. I'm sorry.
I get it. When they did the trial, also it was supposed to be a randomized multi-center trial at 14 different sites, but one site was really the most heavily populated site. It was about 25% or more of the overall study, and that had the results that were the most skewed. So it really looked like the trial results were pushed by one study. What the trial showed was that it's a remarkable finding, and this is actually what got me started trying to push against it. What the trial showed was that in the women who got Makena, they had a 36% rate of recurrent preterm birth. So these were women that had had one preterm birth, then they got Makena. About a third of them, more than a third, still had a preterm birth, and that's actually high. typically when you look at the studies, when women have had a preterm birth, it's about a 20% risk of having another preterm birth. So their placebo, their Makena group had a 36% rate of recurrent preterm birth. So just looking at it compared to historical controls, it would look like Makena failed because it
I
was
mean,
36.
it's even worse. I mean, it's it's
Yes,
worse than it failed. It actually made the problem worse, it
it looked
sounds like.
worse. That's
Yeah.
right. The trouble was that the placebo arm in that trial had a 55% rate of preterm birth, which was just crazy off the charts to have that high a rate of preterm birth in a trial like this. So the only reason Makena looked effective was that it was being compared to a placebo that had a 55% rate of recurrent preterm birth. But despite that, I think people were excited about having something that might treat preterm birth. And because of that, and because of the enthusiasm for moving drugs forward, it actually got approved by the FDA on the basis of that one study.
Wow.
When it went
Okay,
through FDA
so
the first
so
time,
let's go back. So let's go back. So the FDA requires two randomized controlled trials, correct? And this is to prove efficacy, right?
that's right.
Okay,
This, except when they're doing accelerated approvals, which has become
got it.
increasingly common now. A lot of
Okay,
drugs are being pushed through in the accelerated
yeah,
approval pathway.
right. Okay, yep. So what was the basis for accelerating approval for McKenna?
Because of the need, this idea that there
Okay,
was no other drug in that space, there's no other drug treating preterm birth, so that it was important to try to get a drug out there.
okay. And how was the drug administered? Is this something that was given, the patients have to be admitted to the hospital? Could they take this by mouth? Was it an injection? How was?
It's a good question. It's
Okay.
injectable. It's being injected intramuscularly.
Okay.
So it really sort of ups the ante in most people's minds, because now you're not just giving a woman a pill or one pill a week or one pill a day. You're injecting her, and there's injection site. There's pain. There's injection site reactions that women will get from that, from being injected. So, I mean, to most people, when they think like, if you're going to inject a pregnant woman with something, you better be darn sure that it's going to be safe and effective and she's going to need it, because otherwise you're
Yeah.
stabbing her in the arm
Right.
every week
Yeah.
while she's
Yeah.
pregnant. No, that's a terrible idea.
Yeah. Okay. So, all right. Now I interrupted your train of thought. So we got it fast tracked through the FDA process, based on this one trial that really just showed a difference between this high risk placebo group, and the group who actually got McKenna, even though it increased the incidence of preterm
Yeah, it was a very
pregnancies.
it was a very high rate of recurrent preterm birth in the Makena
Okay.
arm. Yeah,
Okay.
remarkable.
All right.
So from there, actually, if you go back and you look at the FDA minutes and their meetings on the original application, so many of the folks at FDA really looked askance at this application and said this drug is not ready for prime time and that it shouldn't be approved. And their chief statistical reviewer at the time said this drug should not be approved based on what the data that we've been provided about it. But despite that, they sort of reworked their application, tried to address some of the things, kept pushing it through. And in 2011, it actually did get approved, but it got approved. The accelerated approval program approves drugs, but it approves them provisionally with the need for a second confirmatory trial to be done. So 2011, it gets approved and the company says, great, we're happy, and we'll do the confirmatory trial. But a lot of people recognize that this is a terrible idea because the company at that point has their FDA approval. There's not a big incentive for them to really
Yeah.
move fast on a confirmatory second study, a confirmatory study that could show the drug's not effective. So a lot of people think that drug companies probably drag their feet, and that's what it looks like they do. And so 2011 was the initial approval, 2003 was the initial study, 2011 the initial approval, and then the follow-up, the confirmatory trial just dragged on, and everyone was waiting for results on this to come out. But in the meantime, people were rushing to use the drug, and it quickly became the standard of care. And this is like an important point I want to make to anyone listening to this, is that these drugs, once they get approved, they become what I would call like a corporate rollout, or it's a corporate product that then gets rolled out. And they get rolled out, these drugs, by the pharmaceutical industry. It's basically the same playbook all the time. They get rolled out as being very safe, incredibly safe, like basically no problems with giving it. They get rolled out as being highly effective. And as I was saying before, and the risks of the condition also get overplayed. So once you get approval for a product like this, it's like the pharmaceutical industry propaganda machine ramps up and starts moving on this. And then that pushes everything towards use, towards people using it. And very few people at that point are asking the question, like, what is all this enthusiasm based on? Like, how safe is it? How effective is it? Once the momentum of the pharmaceutical machine, the propaganda machine, is going on these things, it just starts rolling. And that's what happened here. So quickly it starts getting used. It starts making profit for the company. The company then starts funding the various professional medical societies like the American College of OBGYN, the Society for Maternal-Fetal Medicine. Those societies continue to take money from them, write guidelines supporting the use of the product. And then they even had infiltrated various I think it was insurance companies or state bodies to make it standard of care, so that physicians would actually like get dinged if they didn't have their patients on Makena. You have this real, like, it was crazy, because at the time I looked at this and thought, you may be penalizing a physician for not using a drug that doesn't work. And could be causing their patients harm. But this is the kind of momentum that develops when you get approval by the FDA, and when the pharmaceutical industry is able to put their money and their might behind products.
Okay, so at this point now we have the FDA, which is a federal regulatory agency that's supposed to, protect people before the drug even hits the market, right? And then, okay, we get it approved, but contingent on this plan that they're going to do a second study. Even though this happens, we still get to our major medical organizations who are in charge of also looking out for the physicians and the patients, who take care of vulnerable pregnant people, pregnant women, and these organizations, do they demand, to know a little bit more, about the drugs? Do they understand that the emergency approval is contingent on a follow-up study? Do they understand that at all, or are they really just influenced by, the pharmaceutical kickback that they're getting from it? Because I understand where the insurance company is. That's a whole different entity. But you have organizations that their job is actually supposed to be two arms. You have the medical and scientific community, and then you have the government agency that are supposed to look out for the welfare of patients. And they're, I don't know what's happening. What how do they get to that point?
I think you're describing, Nikki, something very important. I think you're touching on something very, very important. And that is, you're describing like how the system should be. So the medical system, the way it should work, or society, the way it should work, is you should have patients here, like on this side, and then you've got the pharmaceutical industry over here. The pharmaceutical industry wants to sell patients the drugs.
Yep.
But between the pharmaceutical industry and the patients, you really should have all of these protectors working on behalf of the patients. And
Yep.
that protective layer would be societies like medical establishment. So that would be like the professional medical organizations. It would be like the governing bodies like the FDA and like the CDC. It would be even like your health media, your health reporters would be there. Your universities would be there. Your leading research universities would be there. And then your physicians and your top researchers would all be working on behalf of patients to essentially protect them to some extent from the pharmaceutical industry, or not necessarily to protect them, but to make sure that the drugs that the patients were taking or getting were the correct ones. So in that model that you're describing, which is society like as it should be, like a functioning society, you've got those layers, FDA, CDC, professional medical societies, universities, who are all working night and day on behalf of the patients and the public.
Yeah.
But that's not what currently exists in our society. No. So we have a failed society in this sense, because what we have a failed society with is that our regulatory organizations like FDA and CDC, they're funded by the pharmaceutical industry.
Yep.
And our informational organizations, like a lot of our media outlets and our universities, are also funded by the pharmaceutical industry. So what the model you actually have is not pharma here and the public here and the medical establishment protecting the public. What you have is pharma here and the public here, and the medical establishment essentially working on behalf of pharma to sell products to the public. Is what we actually have.
And in the middle there, you have, physicians like you and I who probably participate in clinical trials because we want to get good information about drugs and, for our patients, for the benefit of our patients. But we are, we're pretty much just sort of, we're getting the patients to them. And then they have the control about over the information that actually gets released and reported. We don't have any control over that. We just know what we participated in, which patients that we got involved in the clinical trial, and it's all in the name of doing great things for our patients. We really want to do that, and so, but yeah, we're feeding the system, unfortunately. But we don't really have another way outside of the industry to actually go about studying drugs until they've, been on the market, right? Like we can't even, do our own research about these drugs until they've been on the market. And then from the pediatrician standpoint, a lot of our drug trials are actually happen after they've been approved for adults. So
I just wanted to step back and say that that model I'm describing, it's not 100%, it's not black and white. I don't want to offend. I have friends that work at the CDC, friends that work at the FDA, friends who are health reporters. And so there will be FDA, CDC, health reporters, people at universities who are standing up for the public. That is true. But by and large,
that is true. Yeah, that is very true. By and
large, the way the cash flows, the way the cash cycle works is profitable products like profitable drugs will bring in money to the industry, which they can use to influence the regulators, the professional medical societies, et cetera, to then sell more drug, which will bring more profit, which will continue that cycle. People understand this very well, by the way, with the opioids. People get that. The American Pain Society, for example, the American Pain Society was pushing this idea that pain was the fifth vital sign and you had to ask everybody about pain. And that was a professional medical society basically trying to get people to push pain or asking about pain to then get more use of the drugs. And we see that very well with the opioid, exactly how that cash cycle was working, where the regulators are benefiting, where the drugstores are benefiting, where everybody's benefiting.
Yeah.
And it's not a conspiracy. I always try to let people know that it's not that everybody has to meet in a dark room. So pharma
Right.
doesn't have to meet with the
Right. This is all
universities.
happening out in the open.
It's not a conspiracy. It's just how the money flows. It's how the cash flows. Because if you think about the reverse of this, you say, well, why doesn't the media and the FDA and the CDC and the universities, why don't they take more of a position against some of these drugs and against some of these interventions? But when that occurs, there's no longer any cash cycle, because patients not taking a drug or not using something don't generate cash into the system to sort of fuel that. So the system is almost always fueled towards overtreatment, overuse by the public, just by the nature of the way the money flows. Doing things makes money, not doing things or watchful waiting or taking other approaches, whether it's exercise for obesity or anything else that doesn't lead to a product sale, doesn't lead that cash cycle.
Yeah, yeah, and that is one of the key things that I think patients and and lay people actually have to understand about just in general the practice of medicine. The business side of things is real, and it's a big component of it, unfortunately. And when physicians are part of a system that either takes insurance or they're part of a large, health system that where their salary or their employment is dependent on how much revenue they're bringing in, then unfortunately they're incentivized to actually do more things, do more procedures, prescribe more medications, prescribe, get more labs done, all of these things. And, and again, I mean, there's good and bad people in every single population. But at some point, we do have to take ownership for perpetuating the cycle. And if we are physicians like you and me who care about our patients, want to stop that cycle, then we actually have to push back and fight and ask the questions and make people have the debate. And that's that's an example of something you did with Makena. So I want to go back and because I want to get to the positive piece of this, and I want people to know that to not be completely discouraged, that there are physicians who want to do the right thing, but there's a way that they can ask questions and get their physicians to actually do the right things too, so they can be a part of this process as well. So I want to pick up where you left off, talking about Makena. So we got the drug approved, people started prescribing it, and then what happened after that?
Well, then while we were waiting for the results, or while we were waiting for the next trial to be done, the confirmatory trial, the sort of money machine was running, as I talked about. So they were making millions, billions of dollars on this drug. But academics in academic medical centers started putting out papers saying, not as randomized controlled trials, but saying in a retrospective fashion, like, what is going on here? Is this drug working? Is this drug lowering preterm birth rates? And that observational data was not good. Study after study was showing that it really wasn't making a difference. But at the end of almost all of those research papers, the authors would say, but we're going to be waiting for the randomized controlled trial to come out. Wow. But it was becoming clear to people that maybe it wasn't all that it was being made out to be. Finally, after everybody was waiting years and years on this, in 2019, the second trial, the confirmatory trial, came out, and that was the Prolong trial. It was called Prolong, and Prolong showed that the drug had no benefit whatsoever. It did not decrease preterm birth. It didn't show that it increased it, but it didn't show that it decreased preterm birth. It just was ineffective. It was not an effective drug. And it was a bigger trial that was done. A larger number of patients was studied. So I'll never forget the day that came out. That came out in March of 2019. And I immediately got on the phone and called some of the people I knew at my professional medical society, Society for Maternal-Fetal Medicine, and said, really, we got to jump on this and get this off the market because it's clear now that it doesn't work. And I really thought, naively, now that I look at it, I really thought everybody was going to immediately act and say, the confirmatory trial failed. We got to get this drug off the market, stop injecting it into pregnant women because it doesn't work and it could cause harm as a synthetic hormone.
Yeah.
But,
Oh, wait,
good.
speaking of that, were there harms observed? Like what were the actual effects of the drug, period, besides increasing preterm
Yeah.
birth?
This is my big thing. I have this phrase that I use for patients to try to explain like risks of a medication. I tell them medications are chemicals and chemicals have consequences.
Absolutely.
So you're gonna always have effects. If you're taking a chemical into your body, it's gonna have chemical effects because that's what chemicals do. They have chemical effects. And I tell people medications are chemicals. They're not growing on trees out there. So they're being made in chemical manufacturing facilities. They're synthetic chemical compounds. If you look at people working there, they'll be dressed in chemical suits. And their chemical compounds are going to have chemical effects. So it's just a matter of figuring out what the chemical effects are. And that often takes time. So it's a synthetic hormone that was being injected into pregnant women. Synthetic hormones can cause problems with the liver. So that was the concern. Can cause problems with depression because it's a progestin. And so that became an issue, patients becoming depressed with that. It can cause concern for blood clots. Because hormones have been linked to blood clots. So there were reports of blood clots being associated with it. Certainly injection site reactions were found. Some of the studies showed increased rates of gestational diabetes in the women who were given the injections. And then there were other things, but the biggest other category that's always applicable in pregnancy is unknown long-term effects. To the fetus, because it was a synthetic progestin that readily crossed the placenta. And so what happens is you give this synthetic progestin that's not natural progestin, it crosses the placenta, and the baby's brain is loaded with progesterone receptors.
Yeah.
But this synthetic progestin bound those receptors differently than the normal does. So you're going to have different impact on the developing fetal brain in a variety of areas. And we honestly don't know what that is. There were some animal studies showing harms with the use of this drug. And there was a human study. The other human study, to touch on risks, there was a human study that showed increased rates of cancers, which we've seen before with, for example, DEF or diethylstilbestrol. It was a hormone given to pregnant women that led to cancers in those babies in the future.
Later.
The way to simplify this, though, for people, so I don't want listeners to get all mixed up. It's like if you put a chemical compound into your body, you're going to have chemical effects, and we're going to find that out over time. And if you put it into a developing baby, it's going to be the same thing, except it may take longer to figure out. But that's typically the trajectory of what happens with drug use in pregnancy. Is that we see these things. I get asked. I don't want to do too much of a tangent, but I get asked all the time, like, are these affecting the baby's brain? All these different medications that are being used, Makena or the antidepressants or whatnot, and they're certainly having an impact on the baby's developing brain because they're going into the brain during development. And I focus on the brain because that's the area, of a developing baby where there's really, really rapid development that's relying on a lot of hormone and transmitter systems.
Yeah. And it's really very interesting because I mean, especially if a drug is binding to where a natural hormone is supposed to bind, is that preventing that natural hormone from doing the job it's supposed to do? Or is it taking the place and actually doing that job? Is it doing it, more than that? And then what is the effect of that? Like there's so many questions that we can ask about this. And
that's exactly right,
particularly
exactly right.
The depression and the gestational diabetes, you're adding a medical problem already, in addition to, the whole increasing the risk of preterm, delivery. So now you're also, increasing not only the risk of the pregnancy, but you're also increasing the chances that they're going to be prescribed another drug, right? So
Yeah.
is a chemically induced depression then treated the same way as a natural state, depression? So were these women then, prescribed antidepressants?
We see this all the time in medicine with this cascade of interventions. And you that's definitely what occurs, which is that you get a symptom from one medication or a problem that then gets addressed with another one, which might cause a different problem. And that, I don't know specific cases that I can point to, but I'm sure that was going on. The patients were noticing that changes in their mood, which would then be addressed with another medical intervention. And then if there were side effects of that, it gets addressed with another medical intervention. So you end up on this slippery slope towards polypharmacy. And polypharmacy is a huge problem. I tell people, like, if we step back, we are the most pharmaceutical exposed human beings to ever walk the planet.
Yeah.
I mean, and our brains and our bodies didn't develop with all of this exposure, in particularly during pregnancy. Pregnancy and the formation of a human being and the formation of the human brain was this finely tinkered process worked out over millions and billions of years, never exposed to the soup of chemical compounds that we're currently using. And so, it's something that definitely has to be taken into consideration. As you were saying, when you're going to give something to a pregnant woman, especially when it wasn't helping in the first place. And so this trial, I'll go back just to finish up the story. This trial came out in 2019. The FDA and the prolonged trial, the confirmatory trial, showed that it failed. And much to my surprise and chagrin, it didn't immediately get pulled off the market. In fact, it continued to be sold for year after year. And so I tried to mobilize more, writing letters to the editor and writing different pieces and lecturing on it and whatnot. Finally, in 2022, the FDA held its basically second advisory committee meeting and voted it off completely. And it was pulled off in April of 2023. April of 2023. More than 4 years, it was April 6th of 2023. The prolonged trial came out in March of 2019. I know the dates because it was actually more than 4 years that it got used. And what's tragic is there were a whole bunch of women, some of whom have contacted me through emails, my office, a whole bunch of women who were treated with Makena from 2019 to 2023, but weren't informed, getting back to the issue of informed consent, didn't realize this whole backstory, that it had failed its confirmatory trial, that it might get pulled by the FDA. Like, they were just completely in the dark about that.
So, that's the interesting thing too. So, okay, so the results of this confirmatory trial, which really wasn't confirmatory, it was basically,
Non-confirmatory trial.
Yeah, it was like, no, this drug is bad. We need to pull it from the market. What was the FDA doing during that time? Was it just kind of like, I mean, it's the government, so there's lots of other things that are happening, but they were the ones who recommended this confirmatory trial. So were they alerted to it? Then did they, put a black box warning on it, or what was happening during that time? Like, you told me that you had to write editorial pieces just to get, I mean, were you getting feedback from other doctors? Were you getting, were you being heard from at all about this? I don't know what was happening. How did this not reach the FDA, for 4 years before it got pulled?
This is a crazy part of this story. What happened with Makena from 2019 to 2023 is just a crazy part of this story because it failed the confirmatory trial, and yet you still had so many voices arguing to keep it on. And my own personal feeling is that what had happened is that cash system had become so entrenched that people were like, no, don't take this off the market because it shuts down that whole system for researchers dependent on the company's money, for people using it in the offices, et cetera. And so people were really pushed back. The crazy aspect to it was that race got injected into this. So the company started arguing that because the Meese trial was done mostly in the United States and mostly with Blacks, and
I was going to ask that next.
the prolonged trial was done in the US and Russia and Ukraine with a mixed population, including a large number of Blacks in the US, but a mixed population, that they said that, that the Meese trial was a different population, a Black population, prolonged was a white population, and that we didn't really know what the answer was, and that we needed more time. And then you started having voices arguing that for purposes of health equity, it was important because Black women do have higher rates of preterm birth. So you started having these voices arguing that for purposes of equity, to help the Black community, we had to keep this drug on the market to inject it into Black women, which is an absolutely absurd argument. You're arguing to keep an ineffective drug on the market to inject it into Black women, which
is insane. I don't even, I mean, I was kind of waiting for you to get here because in this heightened sense of awareness about high rates of maternal deaths and maternal complications among Black American women, there's this rush towards this equitable treatment, of care or delivery. But we're doing the opposite of that here. Like, this makes absolutely no sense. We're taking a high-risk population, increasing the risk, again, of preterm pregnancy and delivery, and then adding more risks in a population that's already high risk for death and complications during pregnancy. This is completely insane to me. I just can't, I don't.
This was, I thought, just the worst. I wrote an editorial on this. It got published in Stat, basically making this argument that this was just really absurd. And I felt that it was unethical and underhanded and just really an awful, divisive argument for a company to be making and for people supporting. I mean, I think the folks at the company, the folks at pharma, are trying to keep the product on the market to increase profits, and to be using this race-based argument was just abhorrent, really, and absurd. The absurdity of it, that we need to keep an ineffective drug on the market so that it can be injected into pregnant women Black pregnant women in order to help the Black community.
And in a sense where, oftentimes when there is a problem that is really heightened and people are, have this heightened awareness, you get the crowd that says just do something crowd, right? And the just do something crowd, wants you to come up with a solution for it that, may work, may not work, we don't know, but they will fight for that solution. But most normal people, when they realize that solution is actually causing more problems, they want to stop that problem, right? Like, and in this case, it continued. You could only argue that there was greed or some nefarious intent here. Like, that is completely insane to me. I don't even understand at all.
Yeah, the NAACP actually
I'm blown away.
The NAACP actually put in a letter in support to keep the drug on the market. This is
Really?
back in 22 at the second at advisory committee meeting. Yeah.
Oh my gosh. Oh my gosh.
That's worth pulling up. I was very surprised to see that at the time. Fortunately, though, FDA made the right decision, which was to say, no, the drug doesn't look like it's effective. And they did tease it out by race. It's not effective in whites. It was not effective in blacks. It needs to come off the market. And fortunately, that's what ended up happening in 2023. But it was kept on for all that time and again got 4 extra years. And I don't know who makes these calculations. I mean, I'd like to believe that people have the best interest of the patients at heart, but it looks like it being done in order to increase corporate profits, extend the life of the drug that eventually is going to get pulled off. But for docs who take care of pregnant women every day, like I do, the idea of continuing to inject women with a drug that doesn't work and may cause long-term harm to themselves and their developing babies is just unbelievable. And I still say that like that drug should have been pulled off. It should have never been approved, but it certainly should have been pulled off the market in 2019 as soon as it failed its confirmatory, in this case, a non-confirmatory trial. As soon as that came out, we should have acted quickly because these are pregnant women and developing babies we're dealing with. But that wasn't the case. It continued to stay on and did stay on for more than 4 years.
Okay, we have a comment from someone on Twitter about this, and I'm just going to read it out loud. I believe Dr. Urato is not being fair representing the other argument. You should summarize the points made by SMFM. I don't know, is that the Society of Maternal-Fetal Medicine? Prolong, yeah, Prolong also has a lower overall risk profile, more 36-week preterm births, and less pre-viable, I'm assuming not paraviable or paraviable preterm birth. The concern was that Prolong failed to identify a subgroup of higher risk patients that would benefit from the med. And then in the comment, agree with healthy skepticism towards meds and pregnancy and healthy skepticism towards a race-based argument. Dr. Urato has been incredible in advocating for review of this med, don't get me wrong, but fairness should represent both sides. Okay, so you're going to need to decipher and kind of explain the first part of that for me, and just to see what the criticism is here, because I don't really get it.
That's a well-written question by whoever wrote that. And that's like several important points. So whoever that was, thank you for the question and those comments and some nice things that you said about me there too. I appreciate that. But no, those are important things. They tried to tease out, could there be a high-risk group that it could work in? But if you drill down, and the FDA did this, the FDA spent a long time, and certainly three full or 2 full days. I think it went 3 days. They had I think it was a 3-day advisory committee meeting on this drug in October of 2022. I think it lasted 3 days, and they tried drilling down to see, is there a subgroup that it will work in? And so this intelligent questioner is saying that that is what SMFM was looking at, that there could have been a subgroup that it might have worked in. But if you go back to the transcript on that, or go back to the meeting, you'll see that they went over each group and it was not effective in any subgroup that they could tease out or that they could pull out. And again, the burden of proof is on the drug. The drug needs to really be shown to be effective. So this is one additional comment I would just make to that good question, is that you really want to, before if you're gonna say, okay, I'm gonna inject pregnant women with this thing every week, you want to make absolutely sure that it really is effective. And if you have to tease out and parse the data and torture the data, we say that researchers can torture the data until it says what they want. If you have to really keep doing that, then that really casts doubt on the whole enterprise. If it's that effective, it should be effective, and it shouldn't be something where you have to really tease and parse it out again and again in order to find that.
I think that's a very fair argument. And I also think it is important to mention that you also have to consider the risks and the risk benefit ratio here too. So, if you're continuing to inject these women, if they're having more risks and side effects than they are benefit of the drug too, then that's also a reason to pull it from the market. So,
that's a great, Nikki, that's a great point. That's a great point, because if it turns out that 20 years from now or 30 years from now, we're studying these kids like with DES, and we're finding more tumors, more cancers in kids that were exposed to Makena, or more abnormalities, neurobehavioral problems, it's tough. It's a very non-convincing argument to say, well, we needed to keep giving it to everybody because we really parsed out the data. We tried to keep looking and looking for a possible subgroup of a subgroup of a subgroup where it might have been of benefit. That just doesn't justify the potential harm. You really need to have clear evidence of benefit. I tell patients, you don't want to be on any drug that doesn't have clear evidence that it's safe and that it's effective, that it will clearly benefit and lead to a health improvement. That's really what you're looking for. I just want to quickly jump off from that point. The first study, MEIS, did show the difference in preterm birth, but it didn't even show a health benefit. Those babies in that group in the Makena arm didn't do better. And that's really the bottom line. Yep. We're not just working to get babies to a certain number, gestational age. We actually want healthier babies. Typically, that's if they get farther. But in that trial, the group that got Makena, they actually didn't end up with a clinically significant benefit. And that's really the bottom line. Moms don't want to be injected with something, and docs don't want to be injecting pregnant women with something that doesn't show a clear clinical health benefit.
Yeah, absolutely. And then don't forget too, the important piece in that very first, the MEIS trial was that your placebo group was the higher risk subpopulation. And they had a lower rate of preterm birth than your recurrence than your treatment arm that were more healthy. So so we don't really know, correct, in that higher subgroup if they were the people who would have gotten, some benefit from it. But it's just,
and that data,
how it just hones in on your point that how many times are you going to keep studying it until you get the result that you want from it? What's the end point? When do you stop?
Right. Something that's effective should look effective. And if it's not, and you have to really tease it and parse it out, it really makes you question it. And again, taking into consideration what you had said, there were other problems with that MEIS trial. I mean, the Makena saga would make a good book or documentary someday. There were other problems. The trial was started and then had to be stopped because there were manufacturing concerns and with the drug itself. And so the trial was started, but were stopped. And then there were concerns that the placebo that was being used was related to castor oil, which is known as being a stimulant of contractions. And so people were worried that the control arm had such a high rate of preterm birth because they were given these castor oil injections. And that, to me, has not been completely addressed, but there were so many problems with that original trial.
Wow, that's interesting too. Oh, goodness gracious. All right, we have a question and comment from one of our Fair in Medicine fellows, Dr. Brigham. I'm going to answer live. Another way the system is supposed to be working is through individual accountability for poor professional practice. Is there any realistic possibility of malpractice suits or licensing board complaints related to potential harms caused in these cases?
A great question. I don't know the law and the malpractice law that well. I don't think that would stand because physicians were following standard of care.
Yeah.
So physicians are protected by the standard of care. the organizations, ACOG, SMFM, are protected because it's an FDA-approved product for it. And I think that sort of those layers of protection is part of the problem. Although professional medical societies can be sued, and I believe, I don't know this area as well as pregnancy, but I believe one of the pain societies, it might have been the American Pain Society, actually declared bankruptcy. And I think it was because the litigation that was being put upon them for helping the promotion of so much opioid use. So I think that there may be a way to get at this, but I don't think at the individual physician level. And honestly, most of my fellow physicians who are using this, they're good docs, they're great docs, they care about their patients, and they were hearing that this was safe and effective and recommended by the professional medical societies. And that's why it was being used in a widespread fashion.
Yeah, that's the interesting thing. And I think kind of going to the gender medicine scenario in there, we had a lot of, some of we're seeing lawsuits from the detransitioners having this, type of questions about, either malpractice, from their physicians who prescribed these medicines or surgeons who went ahead with these surgeries. And you have these medical organizations pushing out this information. And I know one of the detransitioners is actually including the American Academy of Pediatrics in her lawsuit for that very reason. And so I think that maybe, that is where we're going to need to go, either hold the organizations responsible, hold the regulatory agencies responsible, but ultimately we're going to have to get to the pharmaceutical lobby. I think that's where the meat is going to be. We have to find a way to make them transparent about these trials, and about this information, because that's all we have to go on, is what they put out to us. And if you have patients who have problems, especially when they're marketing directly to the consumer, and patients have something and they come to you and they want this treatment, and that's all you have. And then you have a medical society saying that this is a priority, and this is now standard of care. You've got an insurance company that's saying, if you're not doing this, then you're not treating your patient properly. We're not going to reimburse you, blah, blah, blah. All of these things. What are we to do? So in the end here, the onus is definitely on the pharmaceutical companies. And that is, that's the concern. And I know in the case of opioids, there were definitely suits against, the large manufacturers of OxyContin. But the problem is this stuff is going to happen after patients are harmed.
Yeah.
So what's the answer? Like what should we do to prevent it from being, to getting to that point in the first place?
I wish I had the answers. I do know a couple of things, and a couple of take-home points I would make, or a couple of important points I would make to patients is, one, to just keep in mind this concept, to never take your eye off the ball, that medications are chemicals. They're synthetic chemical compounds, and they're going to have chemical effects throughout your body on almost all the cells. So if you're taking Advil for pain in your knee or a headache, it's going to go everywhere. It's going into your lungs, it's going into your gastrointestinal tract, it's going into your kidneys. So patients just need to be aware of that. It doesn't mean that you can't use medication. I try to be clear to make that point. Like, patients can use medications, and they do. And there are going to be situations where you're going to use that. But every time you're using it, you have to keep in mind, this is a chemical that I'm ingesting, and what are the chemical effects going to be? There's going to be off-target chemical effects on me throughout my body. Is the benefit that I'm going to get going to outweigh those? So is it safe? Is it effective? What's the evidence? And is there another way to address my problem? Now, a patient might go through all that and come to the conclusion that, no, I need to take this because of X, Y, or Z. And then you take the medication. But you want to go through those steps. realize it's a chemical, realize the chemicals are going to have chemical effects, and then kind of investigate and try to look into, has it been proven safe? How long has it been out? Has it been proven effective?
Yeah.
And are there alternative approaches to this? So patients can protect themselves that way. The second way I think that patients can protect themselves is by sort of understanding how the system works. And again, this isn't to say it's a conspiracy or that you should trust no one. That's not what I'm saying.
Yeah.
But the patients need to remember the FDA is about 50% funded by pharma. So in a sense, they work for pharma. So FDA approval or promotion doesn't mean it's not this outside body protecting the public. The FDA works in some sense for pharma. The CDC gets funded by pharma. So in a sense, the CDC works for pharma. And this is also true of the professional medical societies. So just being aware of this, patients need to realize that they need to go beyond just listening to these expert groups. And one particular way, and you touched on this a little bit earlier, is by listening to other patients for effects. A great example of this, I think you guys talked to Dr. McFillin a few weeks ago, but a great example of this is post-SSRI sexual dysfunction. Patients had been complaining about this for a long time, and it was continually dismissed by all of these layers of medicine, of the medical establishment. But now it's being recognized. And so I think it's important for patients to protect themselves, to listen or look at the experience from other patients. So I guess those are the biggies I would say. Remember that chemicals have consequences. Remember you're ingesting a chemical. Be skeptical about what the experts are saying, especially when those experts are being paid for by the pharmaceutical industry. For example, mainstream media, in large part, if you watch the nightly news, I think half the ads or more are from the pharmaceutical industry. So the way to think about that is that the pharmaceutical industry is paying that news outlet. The news outlet works for pharma. So they're going to be much more reluctant, much less likely to actually cover it in a truthful, investigative manner.
Yeah, absolutely. Yeah. And put themselves at risk for some, sort of legal attack too. And we've seen some things like that happen with other products on major news networks. So it is a tricky situation. Okay, so we know what, I think that's really great advice for patients. But what about the physicians who are practicing? I'm not practicing anymore. So, what's the advice for doctors who are in medical school and training, or doctors who are like not even in an academic center, practicing solo somewhere? How do they find out the right information about medications?
I think trying to dig deep is important. Like I looked at the original study. It does help to go back and look at the original studies. That doesn't help if the data is being hidden, like we talked about with Vioxx, but that's not always the case. In many cases, you can actually see the data and get the information. It takes some digging, it takes some pursuing, but you need to be able to do that. And then I also recommend to my colleagues, and this is the last point I'd make to patients, but also to colleagues, is to try to seek out dissenting voices. You want to seek out dissenting voices because those voices are often proven correct in the long run. They may not be, they may be proven wrong, but at least by seeking out dissenting voices, you're able to get an overview, a balanced view about a drug, who's arguing against it and what kind of good arguments are they making. So it's important. And this is the last big point I'd make to listeners on this.
Before you go on, I think that's a really fantastic point. And I think I think it's very important for all of us to not turn our ears off when somebody's asking questions or giving a different viewpoint about something, because that should really kind of, raise our antennas to think about other things that we might be missing, and not just kind of take what we're seeing at face value. Asking questions is really a great thing. It's how we learn.
Absolutely.
From one another. So yes, and then yes, have the debate, have the discussion. I agree. That's great.
It's
All right.
absolutely right. And along those lines, I am very concerned nowadays with this push towards silencing misinformation. And you hear this all over the place that they're going to try to silence misinformation on social media, Facebook, Twitter, Instagram, whatnot, TikTok, silencing
Yes.
misinformation. And that sounds good to people. It's like, oh, great, we'll have people that are making sure that information that's coming out is correct. It sounds good, but it's a wolf in sheep's clothing. The
Yep.
idea of going after misinformation is silencing dissent. That's the idea behind that.
Yeah.
It's censorship. And who are the censors throughout history? It's the powerful censoring the powerless, and it's the bad guys doing the censoring. That's what it
Yeah.
is.
Yeah.
People
Yeah.
that
Yeah.
want censorship, and that's going to shut down dissenting voices, which are so
Right.
important for getting to the truth of something. During my time with Makena, or after that, they tried to pass a bill, and it was after that, they tried to pass a bill in California. I forget the bill now. It was AB 2049 or something like that, that defined misinformation as telling patients information that was not consistent with the scientific general consensus,
Yeah.
something like
Yeah.
that. But if you think of what I was doing with Makena for years, it was doing exactly that. I was going against the scientific consensus. I was saying this drug that was approved by the FDA and supported by the scientific consensus, ACOG, SMFM, I didn't think it was effective. And that was what I was saying for years. So I could have, I don't know, under that law, if it had been applied to Makena, I could have lost my medical license.
Yeah. Yep.
And the
Yeah.
absurdity of it is that often the dissenting voices are proven correct over the course of time. And so
Yeah.
it's so important to protect dissenting voices. The trouble, I will say, with protecting dissenting voices is it's often or almost always stuff people don't want to hear. So
Yeah.
you have to get it into your mindset as a human being. I want to protect the voices of the people saying things I don't want to hear. Because
Absolutely.
if they're saying stuff you want to hear, it doesn't really even need protection. Everybody's going to want to hear
Right.
that. You want to protect voices of dissent as a way
Yeah.
of making things better for humans.
Right. And the people who are, deciding what is misinformation and what is good information, they're not necessarily the bad guy, but they're the people who want you to believe one thing and not hear the other thing. And so these, like you said, the powerful people who are in control get to decide what is good information or what's the information they want you to hear. And that, sometimes they're well-meaning, but they're shutting down the discussion, and that is a problem. We should always want the discussion. And yes, are some people who are asking questions or dissonant voices really annoying people? Absolutely, they are. But there's also the people who are telling you things are misinformation are also really annoying people. But we have to be thinking, using our thinking caps. And if something is bothering you, why is it bothering? Is it true? First of all, ask the question, is it true? Do you know for sure? Is it true or isn't true? How can you find out? In fact, that should be the next step. Like, why is it annoying you? Why is it bothering you first? And then, is it true? Is it untrue? And that's where we should be going, not shutting down voices at all. Because the way that we advance in society is through having the discussion and having the debate. So
Absolutely. I think you make a
I
really good point with that.
yeah,
Yeah.
I've really enjoyed this conversation. I think it's great. I know that like part of the title we were supposed to talk about SSRIs and pregnancy, but I think really the key here was using Makena as a great example and cautionary tale of about informed consent and what's like truly happening in the practice of medicine in general, and then how kind of the system works and where the problems are in the system and what we can do to help prevent it or at least get around it in the meantime. So I really appreciate you coming on and talking to me. I'm really excited, for the work that you've done, and I can't wait to see what else comes next. And hopefully it's not something that leads to more harm to patients first before we have to halt it. But glad to have you in my corner here. I don't think we have any more questions from our chat or even our live stream audience, but I want to thank everybody who's joined us tonight. Anyone who has learned something new about FAIR and FAIR in medicine, or finds this topic itself intriguing, wants to contribute, has ideas about topics that we should discuss, please let us know. To support our work, go to www.fairforall.org/donate, because everything we do is volunteer, but we can't continue to kind of keep producing great work without your donations. Everything you contribute, even if it's just a few bucks, goes towards productions like this. So that helps us out a great deal. If you have any questions or comments, please email us at info@fairforall.org. And that's it. Thank you for joining us. Good night, good morning, wherever you are.
Thank you very much.